Isidore Kaplan. Isidore Kaplan was in his 80s, and he was a retired lawyer and active citizen. He experienced a series of small strokes that left him with difficulty walking and needing the help of others to get through the day. And then he suffered the big one, a stroke that left him barely conscious, unable to talk, unable to move one side of his body. His 3 daughters gathered at his bedside, and they learnt from the doctors looking after him that he was not expected to survive. But his daughters were surprised to find that there were still medical decisions to be made. Would Isidore want IV fluids, intravenous fluids, that might prolong this period of time? His daughters struggled with those decisions. And 20 years on, his eldest daughter still worries about the guidance that they gave to the doctors. I know this because Isidore Kaplan was my grandfather. And what his story illustrates is the current dilemma of our medical system, of our healthcare. That is, that we can attempt to prolong life beyond a time when people can tell us whether or not they value that attempt. So we can attempt to prolong life or defer dying beyond a time when people can communicate to us whether this is important to them or not. Let's think about how we got here. If we go back 100 years, 1915, the life expectancy in Alberta was about 55 years. And death, when it came, was very sudden, usually after a period of short days or short weeks, often from things like infection. You fast forward 100 years, and today in Alberta, our life expectancy is into our 80s. And how we live and how we die has changed. We've seen amazing advances in clean water, nutrition, healthcare, all of the wonderful technologies. And sudden death has become something of a rarity. All of us in this room can anticipate that our final 2 to 3 years of life, we may be living with several chronic diseases, some increasing disability, needing help to get through the day. And in that period, we will also be vulnerable to sudden serious illnesses that render us into hospital. And what you might not know is that during times of serious illness, it's very hard to think straight, to talk for yourself. And the doctors and nurses looking after you, the care providers, your family, your friends, those close to you, will be asking the question, how do we best care for this person? So that's the dilemma. And the innovation in Alberta in response to that dilemma is called advanced care planning. And I'm going to tell you a little bit about that innovation and about the work going on here at the University of Calgary. But before I do that, I've got a question for you all. How many of you have heard of advanced care planning before coming here this evening? Okay, so you're a pretty engaged audience. I'm thinking that's around 50% of you. When we asked the same question to the public, we did a telephone poll here in Alberta, we found that about 20% of people recognize that term, advanced care planning. And when we describe it, that recognition of the concept goes up to about 80%. So what is advanced care planning? Well, it's a process of communication. It's reflecting on and thinking about your own wishes and values for healthcare, and then communicating those on to others. It has 5 elements to it. So thinking about your wishes and values, learning about your health condition if you have one. What sorts of decisions are you likely to encounter? What sorts of things are likely to happen to you over time? Choosing an agent, someone to speak for you if you couldn't speak for yourself. And then the most important step, communicating, telling that agent what's important to you, discussing it with your other family members or those close to you, and communicating it on to your healthcare team. And the 5th element is documenting. And the document in Alberta is called a personal directive. That's the legal document where you can name an agent and provide some written guidance for that person around what's important to you. Now, this is clearly an iterative process. It's not something that you do once over life, because our wishes and values change, our health conditions change. So it's something that people come to over time. And what Alberta has done is it's the first province in Canada to have a province-wide policy encouraging healthcare providers to talk to patients about advanced care planning. That's one half of the innovation. And the other half is a made in Alberta solution called Goals of Care Designation Framework. Now, the Goals of Care Designation Framework has replaced the old binary do not resuscitate codes that you might be familiar with if you've ever watched a medical drama. And the Goals of Care designations are much more nuanced, because that kind of binary decision does not help people to really communicate what's important to them. In the Goals of Care designation framework, there are 7 different ways to describe the nuanced care that people are looking for, from prolonging life through to comfort care and allowing natural death. And the Goals of Care designations are like a medical shorthand for your healthcare team to communicate what is this person's focus of care, what kinds of interventions might we use or not use, where are we going to care for this person, and are we going to transfer them? Are they going to stay at home for their care? Are they going to come into hospital? So it's a much more informative way of talking about a particular patient's wishes. Let me tell you another story about how this works in practice. So Barbara was in her 60s. She'd lived with multiple sclerosis for 20 years. She brought up her son and daughter, enjoyed summers in her cabin with her family. And she was living at home with her husband when she started to experience a series of serious infections that led her to hospital. And with each infection, she didn't quite get back to where she was before. In one of her hospital visits, she sat with the doctor looking after her and her husband. And this doctor began to explore what was important to Barbara at this time in her life. He shared with her that this kind of recurrent infection was heralding the end of her life, that she was coming to the end of her life. He asked what her hopes were, what her goals were, what her fears were for this time. And together they determined how she wanted to be cared for at this part of her life. She wanted to focus on comfort at being at home, surrounded by her family. And she went home, and with subsequent episodes of infection were treated at home, and that's where she died, surrounded by her family. Her husband had had conversations with her throughout her illness, so he felt comfortable, once she was no longer able to talk for herself, to continue to honor those wishes that she'd expressed. So that's advanced care planning and the Goals of Care designations at work. The research we're doing is telling us that these are not easy conversations to have. There are barriers on all sides. So patients struggle to have conversations. They'll often put it off. I'll wait till I'm sicker, not knowing that when we get very sick, it's very hard to communicate these things. And doctors and nurses put off having these conversations. They're worried that they're going to upset people by bringing up this topic. But we're also finding things that make it easier to have these conversations. For example, if you've ever had to make a decision for a loved one, you tend to be highly motivated to make sure your family know what's important to you. And we're also finding the patients are saying, well, just ask. If the doctor told me about this or asked about it, I'd be happy to talk about it, particularly outside a time of crisis. So our research is helping us to understand how do we best implement this kind of healthcare changing innovation into our complex healthcare system, and what's the impact on people. I want to just spend a moment or two on a different topic, because some of you may be wondering, is there a relationship between physician-assisted dying, euthanasia-assisted suicide, and advanced care planning? Understandably, there's been a lot of media attention around physician-assisted dying, and I want to reassure you that these two things are quite different, and here's why. So the Supreme Court of Canada in February of this year ruled that they will be decriminalizing the physician assistants in suicide as of February next year. And it only applies to people who are competent and have the ability to consent to or request that mode of death. So you cannot, in advance or through advanced care planning, leave instructions for that mode of death. The other thing that I think is much more important to realize is that physician-assisted death is a rarity. So in countries where it has been legalized, for example, in Washington state, only 0.03% of people choose that mode of death. That's less than 0.5% of all the people that die choose that mode of dying. In contrast, advanced care planning is for the 99+% of us who want to have some control, some way to guide those looking after us about how we want to be cared for when we're seriously ill or if we're dying, but who are not trying to hasten the end of our own lives. So they're quite different. So just to summarize, advanced care planning is, if you like, a relatively low-tech innovation for this dilemma of our high-tech healthcare system and all the advances, the wonderful advances we've made that have reduced mortality. 100% of us will still at some point die. It's not all low-tech, though, in advanced care planning, because we do need some high-tech solutions to help us make sure that the conversations that we've had are accessible at the time that we need them later when we're in the emergency room. So as I close, I'd like to ask you one question, and it's this. Who would speak for you if you couldn't speak for yourself? And does that person know what's important to you? Thank you.
Thank you, Jessica. Very good. Any questions for Jessica? Tough topic.
Thank you. I'll just repeat the question if you like.
Thank you.
So the question was around why someone could not give advance notice about requesting a certain form of death like physician-assisted dying. And that's to do with the Supreme Court ruling. So they ruled that patients who wish to choose that mode of death must fulfill certain criteria, including being competent and having the capacity to make that decision.
One more?
Thank you, and I did not plant that question, which is, where would you go to find more information? Thank you very much for reminding me, because we have next door in our question and answer area, the conversationsmatter.ca, our website, and the resources that are being used by Alberta Health Services to help people to engage in advanced care planning, including for you all, if you wish, some further information about it and the sorts of packages that you can take to your healthcare provider. So thank you for asking that.
Last question?
Yes, so the question is around the medical information transportability and this fact that, yes, this is a low-tech innovation to talk about your wishes and values, to communicate those onto others, but how do we make sure that information is there when you need it? Well, we're living in a dual paper electronic world right now in our healthcare system. These are some of the issues that we're trying to address. You'll see something called a green sleeve, which is a plastic folder that's being used across Alberta Health Services to carry the physical paper documents that include personal directive and the goals of care designation orders when a patient has them. So you'll see those over on our booth. And that's, if you like, an interim solution while we wait for our technologies and our personal health records and all of these things to be electronic. I think we'll see that change a lot over the next 5 to 10 years.
Thanks, Jessica, very much.